we look at the landscape, mutation landscape of colon cancer, there are certain things that are important for us. RAS is one that decides or helps us understand the role of EGFR inhibitors versus not. Same for sidedness. BRAF V600E mutations are very important because when they're present, they drive an incredibly bad prognosis. Those tend to be different tumors. In fact, in clinic, those are the patients who treat in first line with FOLFOXIRI, bevacizumab. But in second line, there are rising standards. One is actually on the NCCN guidelines with irinotecan plus vemurafenib plus cetuximab. But there's another one that I think is most promising, and that's with encorafenib, binimetinib, and cetuximab, essentially a RAF inhibitor, a MEK inhibitor, and an EGFR inhibitor, that at least in the phase 1b study with 30+ patients suggested a response rate close to 50% in patients who are refractory, including CRs, but I think 10% complete responders, which in this disease, in the refractory setting, is amazing by itself. So that's an emerging standard. The Beacon trial, which essentially randomized patients to the triplet versus a doublet versus FOLFIRI plus cetuximab, has completed and should report out hopefully by the end of the year. And we may actually see a new standard for our patients with BRAF V600E mutations. Very important to make sure that these are 600Es, because the non-V600E behave completely different. They actually have a very good prognosis and they respond really well to chemo, unlike the V600E. The other target of interest is HER2. Now, two reasons for that. HER2, when amplified, suggests that EGFR inhibitors may not have much of a role. But also we have trials ongoing, one from SWOG, one from the ACRU Research Network. The ACRU network has a study with tucatinib and trastuzumab. Tucatinib is an oral tyrosine kinase inhibitor targeting HER2, very potent, very little non-HER2 activity. And this study is about to complete its first stage and hopefully report on. And then the SWOG study includes trastuzumab and pertuzumab versus standard chemotherapy. It's also ongoing. There are also other studies that are looking at the HER2 question, but all relates back to a study that was done in Europe called Heracles that looked at lapatinib and trastuzumab in the setting of HER2 amplified tumors with a significant amount of responses seen, including some complete responders and very durable responses. Then we've talked about NTRK fusions and MSI high, and hopefully still looking for reintroducing these immune therapy strategies in different shapes or forms into the microsatellite stables. So there's a lot of activity in colon cancer, MSI, HER2, BRAF, NTRK, RAS, and then a slew of other lower yield alterations that are being looked at in smaller studies, from the FGFR to the non-V600E BRAFs, etc. So it's actually becoming a disease that is more than one disease that's closing down that puzzle. We always thought about colon cancer as one or two diseases. Now we think it's 4 to 6, probably 10 or 15 or more diseases, and hopefully we'll have a target for each one of these subsets.